This is the fourth video in our 9-part educational series about His Choice Vasectomy. This video will explain the 7 important steps that are critical to providing the safest vasectomy with the lowest chance for failure. His Choice Vasectomy is the art of minimal combined with the science of providing the most effective vasectomy procedure. There are 7 important steps which contribute to the success of a His Choice vasectomy. No needle anesthesia, no scalpel skin opening, division with cautery, luminal coagulation, fascial interposition, leaving the lower end open, and administering long-acting anesthesia. I will explain what each step involves, and this will provide you with a better understanding. Many vasectomy providers often administer the local anesthetic with a needle. His Choice Vasectomy is a no-needle vasectomy. During a no-needle vasectomy, a handheld spray applicator is used to provide the anesthesia. This spray applicator is called a Monteith. The Monteith uses slightly pressurized air to spray local anesthetic through the skin to a minimal depth. Most men describe this anesthesia like getting lightly tapped on the skin with a small rubber band. Conventional vasectomy, which is a nice way of saying traditional old-school vasectomy, requires a scalpel to create 1 or 2 openings in the scrotal skin. Using a scalpel creates larger openings than are required and can cause more damage to the structural integrity of the skin. This greater skin damage is why sutures are required to close the skin during a conventional vasectomy, and why complications are higher with conventional vasectomy. During a His Choice vasectomy, a specially designed instrument, a no-scalpel dissector, is used to spread a small opening in the scrotal skin. The skin is elastic, and we use this to our advantage. We can spread an opening just large enough to complete the vasectomy. Once the procedure is completed, the natural elasticity of the skin will squeeze the edges back together. Typically, a single opening in the middle of the scrotum is all that is required to complete a His Choice vasectomy, and this opening is often no larger than a Tic Tac candy. Sutures are not required to close a His Choice vasectomy skin opening. A handheld battery device utilizes heat energy to divide each vas deferens. The medical term for using heat is called cautery. By using this heat energy, we can divide the vas deferens during the vasectomy. After dividing the vas deferens, this results in 2 ends, an upper and a lower end. This same device will be used for the next step, which is coagulation of the inside of the upper end of the vas deferens. Coagulation uses heat energy to help the vas deferens close more quickly. After the vas deferens is divided using cautery, the very tip of the cautery device is placed inside the divided upper end. The inside of the vas deferens is called the lumen. Using heat energy from this cautery device, luminal coagulation is performed. Luminal coagulation of the upper end of the divided vas deferens is one of the 2 most critical steps to minimizing the risk of vasectomy failure. This technique causes quicker closure of the upper vas deferens and decreases the chance of a vasectomy failure. The second critical step is fascial interposition. Fascial interposition simply means diverting the upper and lower ends and interposing healthy tissue between the divided ends of the vas deferens. To better understand how fascial interposition works, it is helpful to use the analogy of a disruptive student in a classroom. If one student is being disruptive, we could simply ask that student to be quiet, put them in a corner, or we could even duct tape their mouth. Or we could just simply send them out of the classroom. Temporarily sending the disruptive student out of the classroom is the simplest and best option. And this is just what is done during a vasectomy with fascial interposition. During a vasectomy end, the lower end is the disruptive student. The lower end is the end that contributes to vasectomy failures. To deal with this disruptive student, we send them out of the classroom. So during a His Choice vasectomy, we temporarily divert the lower end away from the upper end. We close the door on the lower end by interposing healthy connective tissue. After the vas deferens is divided, the upper and lower ends are separated from each other by placing healthy connective tissue in between the separated ends. The lower end is diverted ever so slightly outside of the protective tissue that covered the intact vas deferens. The diverted lower end is held in place by a small titanium clip, and this small clip keeps the protective tissue between the upper and lower ends until the ends can heal close. Fascial interposition is the second most critical step in decreasing the chance of a vasectomy failure. Conventional vasectomy often involves removing a piece of the vas deferens and closing both the upper and lower ends with either suture or clips. Unfortunately, these older conventional vasectomy techniques are associated with much higher failure rates than His Choice vasectomy. If we were working with a metal or plastic pipe, then closing the open ends would be a good idea. But these techniques don't work as well with human tissue and cause a higher chance of failure. If you tie or clip the upper and lower ends too loosely, then fluid can escape through the lower end, push through healing tissue, and reconnect to the upper end. If you tie or clip the ends too tightly, then the tissue underneath will necrose or dissolve from a lack of blood supply, and the divided ends will easily open within days, and fluid from the lower end will easily reconnect with the upper end. With this explanation, you should better understand why coagulation of the upper end, diverting the lower end, and interposing healthy tissue can provide a lower chance of vasectomy failure. During conventional vasectomy, the divided lower end is often sealed closed with suture or titanium clips. During a His Choice open-ended vasectomy, the divided lower end of the vas deferens is allowed to remain open. This allows sperm to gradually leave the lower end. The body will form a small nodule around this open end and will become the sperm recycling center. The intent is to have sperm degraded in the recycling center and not in the epididymis. Some studies suggest an open-ended technique may result in less pain during vasectomy recovery when compared to conventional vasectomy. It has been suggested that an open-ended technique minimizes buildup of pressure in the lower end, minimizes disruption of the epididymis, and minimizes any resulting inflammation and discomfort. Some men naturally have concerns about leaving the lower end open because it seems like an open-ended technique could increase the chance of vasectomy failure. In life, what often seems to be true is not always accurate. Most medical studies demonstrate vasectomy failure rates are not increased after an open-ended vasectomy. Studies on the failure rate of open-ended vasectomy using the techniques of coagulation of the upper end and fascial interposition after diverting the lower end demonstrate an average 0.3% failure rate. This is about 3 men out of every 1,000 men who have a vasectomy. This type of vasectomy procedure is considered one of the most effective vasectomy procedures. After you heal from a vasectomy, you may feel a small, painless nodule in each vas deferens. As healing occurs, the ends of the tubes will lie next to each other, and when examined from the outside, may feel like a pea-sized nodule. We like to emphasize nothing is removed during a His Choice vasectomy, and when you leave the office, you will leave with the same stuff you had when you checked in. We have learned the more destructive you are with your vasectomy technique, you may be increasing vasectomy complications and increasing the chance of vasectomy failure. For His Choice vasectomy, the old adage of less is best seems to be very true.